So welcome everybody. We are here in Madrid in 2025 in the ESC Congress, the biggest Congress in cardiology. I am in the Tunisian Society of Cardiologists and in the global community, and I am very happy to introduce Professor Achenbach, the past president of the European Society of Cardiology, a cardiologist, a general, and also an interventional cardiologist. And here we have hotlines and big news in this Congress. And I think in heart failure also, and interventional cardiology, there is a big news. So what about DIGIT-HF study?
Yes, I mean, it's a pleasure to be here, Selma. Thank you for having me. Indeed, this is a great Congress. We have more than 32,000 people attending already, and it's only day 2. So we are very excited also about the science that is presented. And one of the trials that was presented very early at the Congress was the DIGIT-HF trial. And I found this very interesting because I've been in cardiology for a long time, as opposed to you. You are very young compared to me. Good for you, bad for me. When I started, all of our heart failure patients received digitalis. And then it stopped completely because there was some data that actually it was having an increased mortality to treat patients with digitalis. But Johann Bauersachs from Hannover, he came back and he said, you know, the sub-analysis say that the dose is too high. And the sub-analysis in the prior trials say that if you have a low dose of digitalis treatment, patients might actually benefit. So he randomized in a trial that was not industry funded. It was German government that funded the trial, 1,200 patients with severe heart failure, ejection fraction less than 40% and severe symptoms. And he randomized them in addition to the normal therapy to have either low dose digitalis on top. He used the digitoxin, which is used in Germany a lot, at a starting dose of 0.07 milligrams per day, which was then adapted according to lab values to potentially even lower dose, 0.05 per day. So low dose of digitalis, and in addition to the normal therapy, and patients were followed for 36 months. That's a long time. And the outcome was significantly positive for the digitalis group. There was a combined endpoint of mortality, total mortality, and heart failure hospitalization. And both components showed a benefit of digitalis therapy about 2%. The mortality was about 30%. Mortality, 30%. These are sick patients over 36 months in the placebo group and about 28% in the digitalis group, so 2% difference. And there was also this 2% absolute difference in hospitalization for heart failure. So overall, a positive trial, significantly positive, even though, of course, the absolute difference of both taken together, 4%, is relatively small, but a significantly positive trial. Probably because of the low dose of digitalis that was used.
Okay, so digoxin, it will be a solution in some heart failure patients, even if not in atrial fibrillation, because we think it's just for EF, but also for the other one, yes. It seems good.
All of the subgroup analysis didn't show a signal,
yes.
But there was one group that was positive or the other one was not. I mean, we have to say that the patients were on intensive medication already, 96% beta blockers, almost everybody had ACE inhibition, 40% were on ANI, SGLT2 inhibitor use was relatively low at 40%. But so this means that if you have a patient who is optimally treated and you want to have some additional benefit, at least you should consider potentially add digitalis. Today we had another trial that was just presented very shortly with vericiguat.
Yes.
Another trial in heart failure, which was previously only positive in patients who had decompensated heart failure or recovered from decompensated heart failure. But now we had Victoria, the trial in chronic heart failure patients, and it also showed a positive impact on mortality, even though the primary endpoint, mortality plus hospitalization, was not reduced, the mortality component was reduced. So that's another interesting signal. So potentially, in addition to the optimal therapy that we already have and that we try to achieve in every patient, there might be additional things that we can do to really do the best for our patients.
Exactly. So I think that in heart failure patient, we we have some solution today, and it's really great news for our patient.
I mean, if we have another minute, of course we have to put it into perspective. We are helping the patients. Look at the numbers in DIGIT-HF. We're reducing mortality. The exact numbers was 29% to 27%. So reducing mortality absolute by 2%, but we're still looking at a 30% mortality over 3 years. And the age of these patients was 66 years. These were not very old patients. So this is a terrible disease, and we're offering them some benefit, but we're not solving the problem.
Yes.
It's still very sick patients with a bad prognosis.
We need data and further studies.
And we need to take care of these patients very
Yes.
intensively to do the best outcome for them.
Thank you very much. And this
My
is
pleasure.
the role of the Society of Cardiology, the international and national society, to promote science to the healthcare, I think.
Absolutely. Thanks for
Thank you.
having me.
Thank
Great
you.
pleasure.